Welcome to the Stopping Sepsis in Virginia Hospitals and Nursing Homes conference call. On today's call, at this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note this conference is being recorded. I'd now like to turn the call over to Deb Smith. Ms. Smith, you may begin.
Thank you, James, and welcome, everybody. I'm really appreciative that you took the time to join us today for this Stopping Sepsis in Virginia Hospitals and Nursing Homes call. As James said, my name's Deb Smith, and I'll be your guide for today's webinar. I want to remind you that your lines are on mute until the question and answer, when we'll open up the lines for all your questions and comments. Please be as attentive as possible to this webinar presentation. That way we get as much information from the webinar and our peers as we can. However, we certainly understand competing priorities. So this webinar is being recorded for future viewing. We do have a question in chat. So if you're on the webinar, I'd appreciate if you answered that question. It's not a hard one. It's, do you have plans for your summer vacation and where? We're using that question as a type of roll call for attendance, so we don't have to go back through and ask about everybody who is on the line today. So for the next hour, we'll be providing you with an overview of this special innovation project. We'll be introducing you to our teams and your peers who have joined this important improvement project with you. We'll review a timeline for the project and give you a peek at the tools and resources that will be available to you at no charge through the project. We'll make sure that there's plenty of time at the end for your questions and comments, but please use the chat box at any time during the presentation, since we do have Candy Hamner in the chat monitoring the chat box. Candy's the lead for this project and has been working with the Maryland hospital or nursing homes for the last year. First, I'd like to introduce you to Sheila McLean. Vice President, Sheila directs the Nursing Home Improvement Network and this Virginia Sepsis Special Innovation Project, among numerous other projects at HQI. So Sheila's just going to kick off this presentation today and introduce the rest of the team. Sheila, the floor is yours.
Thank you, Deb, and welcome, everyone. Thank you for joining us. Here you see on this slide our Nursing Home Improvement Network team members. And I would love to introduce you to Teresa Mandela, Lisa Mark, and Allison Spangler. Our team has a variety of backgrounds. We have nursing home administration, director of nurses, as well as pharmacy nursing, and certified MDS coordinator. So just a wealth of knowledge and expertise on our team. Moving to our sepsis support team, the wealth of support and knowledge extends there as well too. The happy, smiling faces that you see here are our team members at HQI and VHHA. Deb Smith, who has already introduced herself, will be working directly with the nursing facilities in Virginia. And then Candy Hamner is Deb's counterpart in Maryland and has been leading a similar project in nursing facilities in the state of Maryland. Hospital side, Betsy Cole and Wanda Clevenger from VHHA will be working directly with the acute care hospitals in Virginia on this initiative. The hospitals are having a similar webinar that we're holding today for our nursing facilities on January the 30th from 11 a.m. to noon. So I think most everyone on the call knows Health Quality Innovators, known as VHQC, but just in case we have a few new people working with us, I'd like to do a brief introduction to HQI. We are a private, non-profit healthcare consulting firm that has 30 years. And recently, in 2014, CMS restructured the QIO program and made it a little bit more of a regional program, and we now include Maryland as part of our QIO program. And most of you also on this call, we have our larger overarching initiative known as the Nursing Home Improvement Network. And some of the goals of the Improvement Network is to decrease the use of unnecessary improve quality measures and STAR ratings, decrease potentially avoidable hospitalizations and rehospitalizations. And then under the umbrella of the network, we have some smaller cohorts that are working with us to reduce C. diff and implement antibiotic stewardship programs. And then our cohorts with our two special innovation projects in Maryland and Virginia focusing on preventing sepsis. And today, this presentation and discussion is going to be focusing on the Stopping Sepsis in Virginia Hospitals and Nursing Homes initiative. So, Deb, I'm going to turn it back over to you to get into more details.
Thank you, Sheila. I am just so extremely excited to be back on the call today. This is a special innovation project that's funded by CMS, and its goal is to bring hospitals and nursing homes together to reduce sepsis mortality. So we'll be working together for the next 2 years, sharing best practices, tools, resources, and identifying ways that we can improve patient care between hospitals and nursing homes. So we are so excited to welcome and introduce these 34 participating hospitals. So many of you on the phone are working with these hospitals, some of these hospitals, and hopefully during this project you'll have an even better, more open relationship with them. And then, drum roll please, this is our list of 35 nursing homes who've joined the hospitals in this project to stop sepsis. So I'd like to welcome everybody who's on this call and not on this call. It's extremely wonderful that all of these people have signed up, all these facilities have signed up to work on this project with us. So this is a list of sepsis facts. Where our hope is that it'll help you connect your staff to the reality of sepsis. So many people just don't understand the prevalence of sepsis and are surprised to hear these numbers. So as you can see by this graphic, 1 million patients are diagnosed with sepsis each year, and of those patients diagnosed, 50% or 500,000 will die. Sepsis is the leading cause of hospital admissions from a nursing home. So these are really staggering results. But it gets even more staggering when we look at the Virginia data this way, keeping in mind that these are our patients, families, and neighbors living in Virginia. In 2015, there were over 3,400 nursing home residents admitted from the nursing home to the acute care with a diagnosis of sepsis on admission. And of those 3,400, 780 will die within 30 days of discharge. That's 2 out of every 3 nursing home admissions for sepsis that either die in the hospital or within 30 days of discharge. That's really powerful. This is a different way to look at this. This is the statewide data that's showing discharge data for the top 10 discharge diagnoses that lead to readmission within 30 days. This data is as of quarter 1 in 2016, and as you can see, sepsis is number 1. But it's not just number 1. It's almost double the second diagnosis, which is COPD, and it's ahead of heart failure, UTIs, and pneumonia, which we usually hear a whole lot more about. So in order to understand sepsis, we need to discuss the body's inflammatory response that can be triggered by, among other things, an infection. So the systemic inflammatory response syndrome, or SIRS, S-I-R-S, criteria is listed above. You have to have at least 2 of these criteria to meet this definition. So keep in mind, though, that this is actually the body's response to infection. SIRS, in the presence of infection, that's what indicates sepsis. And then if you don't treat sepsis, sepsis can go on to be severe sepsis or septic shock, which is sepsis plus tissue or organ damage is severe sepsis, and then septic shock is metabolic failure or death. So simply stated, sepsis is a medical emergency. Every hour, a resident who has sepsis and waits for treatment, the likelihood of death increases by 8%. So sepsis can originate from an infection, and then if it goes undetected and left untreated, death. In fact, sepsis is the primary cause of death from infection. So it's important for staff to understand for sepsis to occur. So when any of our residents has a source of infection, for example, an indwelling catheter, upper respiratory illness, diarrhea, C. diff, or open wounds, we need to be really vigilant. This is when there's a potential for serious infection and sepsis. Fear of these residents can keep you a step ahead and may even save a resident's life, or probably will save a resident's life. Mortality rates increase with severity. The mortality rates for sepsis, if we can identify it and treat it early, is 10 to 20%. If we don't and it goes on to severe sepsis, it's 20 to 50%. And those patients that go on to have septic shock, it's 50 to 80% mortality. One of the benefits of joining HQI to stop sepsis is that we have developed a toolkit to help you identify sepsis sooner. This toolkit was developed during nursing homes, and it's been tweaked and is really a super tool now. And on today's webinar, we're introducing these tools. And in the next few weeks, we'll be sending you out a hard copy of the tools in mail. Then we'll contact you by email once they're mailed so that you know that you're going to be looking for them. That will be followed by a thumb drive with all the tools and resources, even more resources than what we're sending you in that packet by mail, so that you can use it and reproduce and share it. The thumb drive will come a little later on. I want to draw your attention to this wonderful website. If you have not been on it yet, it's a good one to get on. It's a great website to use for tools and resources about sepsis. It was developed for acute care hospitals, and then we were given permission from the Minnesota Hospital Association to use these tools. Many of the tools were then changed to be used specifically for long-term care and nursing homes. So these are the first 5 tools that we'll be supplying to you for your toolbox. We'll introduce more over the next 2 years as we identify specific needs projects. But we're going to be going over the Seeing Sepsis 100 pocket card, sepsis rapid identification tool, an algorithm, the SBAR, and a patient and resident flyer. So here's an enlarged example of the Seeing Sepsis 100 pocket card. It's one of the tools that you'll receive. It emphasizes what the frontline staff should do if they notice that the resident has a temperature over 100, a blood pressure below 100, and that's systolic, or a pulse rate over 100. So 100, 100, 100. It makes it really simple. And this tool can be used by everybody to identify this tool too, just so you know. Once it's identified, the frontline staff will need to go to the charge nurse or nurse in care for the resident and let the nurse know their concerns. This is to alert frontline staff so that they can go to their nurses, and then the nurse should immediately assess the patient and provide communication to the provider. This is the first crucial step in early recognition of sepsis and the path to saving a life. So keep your pocket card at all times. Everyone, including the family, nursing assistants, and all clinical staff, must be aware of these early signs of sepsis. So keeping the card in your pocket with you at all times reminds you to be looking for these symptoms. So in your packet that you'll be receiving from us, you'll receive 25 of these pocket cards to review and then pilot in your facility. So if you like them, HQI will provide the template for you to print them yourself in-house, or the instructions for you to have them printed. So now you've identified that, and you notified your nursing staff. So what does the nurse do now? This flyer reminds us to act fast as time works against us when a resident has sepsis. As we stated before, the likelihood of death increases 8% every hour a resident is in septic shock and is untreated. So on the right-hand side of this poster is the reminder of that 100, 100, 100 pocket card tool. And then on the left are the steps that the nurse will be taking. So we're going to cover the receiving 5 of these flyers in your packet. You can place them in an area that will be convenient and accessible to all, areas like the nursing station, a med cart, a med room, break room. The idea is to keep sepsis and the need to act fast in the forefront of all staff's minds. So as with the pocket cards, you'll be provided with a template to reproduce these flyers in-house or order them from a printer. So let's break this down. The nurse must take the next step and do an assessment. So the nurse should check, does the patient have a source of infection? Then, does the patient meet at least 2 of the criteria listed, which is the SIRS, or Systemic Inflammatory Response Syndrome criteria. Now, this goes into a little bit more detail than the 100, 100, 100 screening tool. Remember, the 100 tool is a frontline caregiver tool just to alert the nurse to a potential issue and to do a further assessment. So we're looking for temperature above or below, above 100, below 96.8. Pulse above 100, decreased blood pressure, respiratory rate increase to greater than 20 with O2 sats less than 90% and altered mental status. The next step is knowing what your resident's wishes are. So these advanced directives are critical at this point so that the decisions made for treatment align with the wishes of the resident. Then you need to contact the physician with all of the information, and you can use the SBAR, which we'll be talking about a little later in the presentation, and then make sure that you're alerting the family. Once the nurse has spoken with the physician, and it's been determined that the resident should go to the hospital, this is the list of things that should be done. So you may want to alter this. The steps could be different. They don't have to be exactly in this order. There's slight variations. But you do want to take the time to specify who does each step. Addressing this before a crisis saves a lot of time. So is the report faxed or called? Who does the calling? Is it the charge nurse and a nursing supervisor? Does your provider directly contact ED providers? Who prepares the transfer sheet and who calls the ambulance? So try to address all these, and you probably have these all addressed, but just make it known to staff. So all facilities are a little different in their capabilities. If your facility does have the capability to draw labs and start an ID, so you don't want to hold anything up in the transfer, the faster the lab results, and we're really especially talking about lactate, are obtained, the better. Also, the blood culture should be drawn before any IV access is started and before antibiotics would be started. Many residents have chosen to be treated at the facility, and they don't want to go to an acute care hospital. So every facility has its capabilities, and this is a good time to talk about them with your staff. So what can you do within your walls? And it's really important to still consider, well, always consider, what are your residents' wishes. So if you're able and it's consistent with the residents' wishes, draw blood for a CBC at a lactate level. The lactate level actually tells your providers the stage of sepsis. Confirm infection by doing a urinalysis, culture and sensitivity if possible, and blood cultures. And make sure that you're not drawing blood cultures from an IV line, especially if fluids were in that IV line, because that can distort your results, and we do want accurate results for the blood cultures. And then rehydration is critical for a patient. Started as soon as you can and get fluids on board. So remember, the odds for recovery are higher the earlier the possible infection or sepsis is identified, and the faster. If the resident is staying in your facility, you'd observe for decreasing decreasing systolic blood pressure below 100. Both of these are signs that your resident is not improving. So at this point, you want to consider the next steps, such as comfort care or transferring to hospice, depending on what the advance directive is. But you also want to address the pain control and fever. Make sure you're doing these basic patient care of repositioning every 2 to 3 hours and oral care. These are going to be really sick patients. Making sure that they're hydrated and offering fluids, and always keep the family informed. So if you're the type of person who prefers an algorithm, which that is so me, I love algorithms. They make it really simple for me. This tool has the same information as the ACT-FAST flyer, and it can be used in the same manner. Also, you're going to be receiving the same amount. We'll be sending you 5 of these that you can post in those areas where they'll be seen and used. So as I mentioned, the SBAR Communication tool is an organized tool that will help you report to your physician. It's situations. You want to make sure that you're stating the situation, the background, the appearance, and then review and notify. In this situation, you want to make sure that you're clear and you briefly define the situation. So, for example, Mr. Jones has not been acting like rate is 24, and as from previous slides, we know that this could possibly be sepsis. Within the background, you want to make sure that's clear, relevant background information that relates to this situation. So in the above example, you could consider including the patient's diagnosis, who the prescribing physicians are, the dates and dosages of medications, along with any information about a possible infection that you may have assessed for. And with the appearance, this is your statement of your professional conclusion. So the resident appears lethargic and confused, which is a change from this morning. They're now febrile, and there's a possibility that this resident could be septic. And then with the recommendation, this is what you need from the individual that you're calling to report to. So, for example, do you need to draw blood cultures, establish an IV access, or start fluids? And make sure you let them know that the resident's advance directive states no transfer to an acute care facility if that is the case. So there's a number of different SBAR tools out here. You may already be using. And as long as you use the process, you can use whatever tool you want. And we're going to include a couple examples of SBAR tools. They'll be on the thumb drive that you'll receive in a couple months. Interact, which I hope everybody on the phone has had a chance to look at the Interact website. It's just tons and tons of information for long-term care. Interact is the interventions to reduce acute care transfer. And it's a quality improvement program that focuses on the management of acute changes in resident conditions. It includes clinical and educational tools and strategies to use in everyday practice in long-term care facilities. The Interact does have an SBAR tool to use that's specific to long-term care. They also have a capabilities checklist, which in future webinars we're going to be talking about. But it's a nice way to determine what can be done in your facility. And then this example of an SBAR was a tool that was shared by Shady Medical Center in Maryland with the nursing homes in the Maryland Stopping Sepsis project. So this really positive things about this project is that we can share tools and resources. So if anyone on the line today has an awesome tool that works for you, it's tried and true, I'd really appreciate it if you shared it with me so I can include it in the resources and make sure that everybody else gets it, because there's no sense in all of us reproducing the wheel. If you have something that works, we'd love to be able to share it with everybody. HQI has also developed this really cool brochure that you can use and hand out to your resident families in order to help the family help you identify sepsis earlier. So this flyer was produced, again, for the Maryland Sepsis Project, but just recently it's been reviewed by the HQI Patient and Family Council. So they've looked at it and tweaked it and made a couple changes to make it easier for residents' family to use. Once again, you're going to receive 25 copies of this flyer to trial in your facility. And I forgot to mention about all of these tools. We welcome and appreciate any feedback that you have. So once you've received the tools, if you've got feedback, positive, negative, a lot of times we learn more from the negative feedback or the changes that need to be made. But we want to hear about it because we do want to keep making things better. So just as a back to the beginning type of reminder, caregivers and frontline staff are most likely to be the first to become aware of the early warning signs of serious infection like sepsis. Simple instructions on what to look for when something is just not right will help them to be the resident's voice and advocate for their resident when the resident's not able to do it themselves. A little bit about, what are we going to be doing over the next 2 years? What's our timeline? So we will be having monthly nursing home calls. They will be held the fourth Tuesday of every month. Quarterly, during that same time, we'll be actually combining the calls with the hospital and the nursing home. So while the nursing homes are having their monthly calls, the hospitals are too. We're going to be reviewing data, and we're going to be sharing. Hopefully, we'll be sharing case studies of interest from transfers and anything else that we identify during the month before the quarterly call that needs to be kind of brought to light. Anytime there's any education that can be crossed over within the nursing homes and the hospitals, that's the type of thing that we want to know about so we can share that on those calls. There may be some regional calls that we might, be splitting the state up into regions and a possible face-to-face event, but those are still to be determined. So just like HQI has a team of improvement consultants and other support staff working together to success, we're asking you to do the same thing in your facilities. So think about who should be on your team to assist you in this work. Teams assure continuity and they build in sustainability. There's still some of the facilities out there who have not completed and returned this team's contact list to us. So I'll be sending this link out again, but here it is too for your contact list submission. So let's try to set this to be done by the end of this month. We had originally asked for this to be done at the end of December. Everything just kind of blew up with the holidays and all, and we were still recruiting. So we're asking you again to, if you have not done this yet, please complete it and get it back to us. And just speaking about teams, I want you all to consider me as one of your team members. So if you have questions or you need help on a call or something like that, I want to add value to this program and to your team. So please don't hesitate to reach out to me. We also need to develop education and resources based on the aggregated results of this assessment, the baseline infection prevention assessment. This is going to show us where to start based on gaps in the whole group, like all of our recruited facilities infection prevention programs. So I'd like to, again, work towards 100% of this team, the recruited nursing homes working together on this project, to submit your assessment by the end of February. So I know this is lots of homework, but hopefully it shouldn't take more than about 30 minutes to complete it. There's a lot of questions on this baseline infection prevention assessment, but unknown is an answer, and it's an option. So we just want you to pull it up and answer the questions as you know it right at that specific time. If you know that one of the processes are important, no. But if you aren't quite sure, putting not known at this time is perfectly acceptable, and it gets this done a lot quicker for you. And there's also required monthly data reporting for the nursing homes involved in this project. So as you can see here, total admissions to the hospital for any cause, and then suspected sepsis admissions to the hospital. All-cause 30-day readmission to the hospital, and then 30-day readmission to the hospital for sepsis. The total number of nursing home infections, and the total number of suspected and or confirmed sepsis cases in your nursing homes. I'll be emailing you a SurveyMonkey link each month for this data submission. So this is required monthly data reporting, and the reason it's required is because we want to make sure that we have the best data possible when we're aggregating it and comparing the facilities that are in this project. So this is really an exciting slide. Those of you who've already joined the HQI and Nursing Home Improvement Network, NHIN, are well aware of Box for accessing your data reports. So it's a great tool that you'll have access, and you'll be able to get into your Box account 24/7 and pull up any of the data that's ever been submitted to you from HQI. We really, really, really need to be diligent, again, about these monthly data submission deadlines. I feel like I think everyone on the line is going to know I'm beating the bushes to get this done. I really like complete and accurate data reports. And I'm always out there to help you troubleshoot. So what is Box? If you haven't heard of it, or if you just haven't gotten into it or haven't been reminded about it if you are in NHIN, Box is a secure way, it's a secure file that HQI can use to transfer your nursing home specific information that normally would have to be encrypted if we were trying to send it by email. Over the next week or two, you're going to receive an invitation from me. It's an email invitation with a link to activate your box account. But the problem with this is that this link will expire in 7 days. So you have to act immediately when you get the invitation. So think about it and put it, aside for a week or 10 days, and you go back and pull up that original invitation that I'm out in the next day or two, week or two. That link will no longer be valid, and you won't be able to do it. Along with that link, I'm also going to send you detailed instructions with screenshots. Sometimes, though, that's not enough when you're going down through and you're trying to look at it. So help, my help, anybody else's help box, it's only an email or a phone call away. Please don't hesitate to reach out to me once you get this invitation. This is such an easy way to access your data after everything's been set up. But the challenge is in getting it set up. So let's all work together so that everyone our information inbox. And why would you want to do that anyway? Well, because we've actually got the 2015 baseline data that we've been using, and it'll be available beginning February. The only way that this data is going to be available is through your box account. So we really want you to be able to see and use the data, share it with others in your facility, especially leadership. So it's important to work with me to get these box accounts up and going. Once you do get your data, if you want to set up a time to review your individual data with me, I am happy to do that. Remember, I'm part of the team, and I'm there for you whenever you need me. We will be reviewing on the February call, so that'll be actually the hospital and nursing home aggregate data for the 2015 baseline. So, combined hospital and nursing home webinar where, like I said, we'll be presenting the baseline data for both hospitals and nursing homes. I will discuss the data collection, and we'll also have a brief overview of patient and family engagement. Our patient family engagement council lead is joining us for that webinar to tell us about patient-family engagement, and especially what we're doing here at HQI. Now, take note, February 27th is not the fourth Tuesday. It's actually a Monday. There were some scheduling conflicts with that Tuesday, so this webinar only is going to be on Monday. Still the same time, though, from 11 to noon. So, it is now your chance to talk with us, to give us some comments, to ask some questions, feedback, whatever. James, can you let everyone on the line know how they can ask a question?
I sure will do.
Okay.
As we said, we can now begin the question and answer session. If you have a question, please press *1 on your touch-tone phone. If you wish to be removed from the question queue, press the pound sign or the hash key. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press *1 on your touch-tone phone.
Thank you.
We do have a...
Hi, Heather.
Hi. I am wondering what is the first due date for our data?
The first due date for your data is going to be, I'm going to call on Candy to help me out with this. We're going to want you to start collecting the data in February. So Candy, Candy's been doing this for the last year. Are you sending it out around the 15th, or when do you send out the Survey Monkey?
I usually send out my email by the end of, I like to give people 3 weeks beyond the due date to have their data. So if it's due for February by the 3rd week in March, I send it out in the first week.
And I will.
So you're saying the February data will be due by the third week in March?
Yes, usually that's Friday. And you'll get an email with give you the date. If Deb follows the same process, she'll send out an email that'll have the link and the date that we would like to have it submitted.
Okay, great. Thank you.
Thank you for the question.
And our next question from Claudia Amin.
Hi, Claudia. Claudia?
Hi, can you hear me?
I can.
Thank you.
Oh, okay. Well, thank you. Thanks for joining.
And a question from Wanda Clevenger.
Hi, Wanda. Wanda is our lead.
Oh.
Are you? No, is Wanda there?
Yeah, she's there for that, but you're right. I did this by accident.
Oh, okay.
I didn't have a question, but I thought you did a great job, Deb, and I welcome working with all of the nursing homes in the area. I, too, am looking very forward to the project, and there's a lot of work ahead, but I think there are many tools out there, and we can all learn from each other.
Thank you, Wanda. And just as a reminder, Wanda is working with the hospitals in this project, and she is actually VHHA, who is subcontracted for us to work on the hospital work for this project. So we are so glad to have you aboard.
Thank you.
We do have a question from Jeremiah Finch.
Hi, Jeremiah.
Hey, how are you?
I'm very good. Thank you for joining.
Awesome. Thanks for having me. So I know this isn't quite the direction that it's intended, but it is relevant for, we've been, like many Smiths, have been battling with readmissions for some time here. What are you wanting us as far as reporting for the 30-day readmission rates? What are you using as a definition of a readmission? Because I've got about 3 floating around that I use between what the hospital's measuring, what we're measuring as a company, and the way our outside vendors, and they never match up. What do you want us to report to you?
I will have to look into that. I did not. Would you mind, Jeremiah, sending me the 3 different definitions that you have for readmission?
Sure. It gets a little complex when, like, for some, for reimbursement penalties, it takes into account, they call them like covariates and exclusions. Basically, this is a really sick patient. This one actually doesn't count against you, for example.
Well, I know that we are pulling, we have an analyst, Jennifer Chang, who will be on, by the way. She'll be on the call in February, that sharing call. She pulls data from the claims data for this. So I am not 100% sure exactly what that readmission data is then.
Deb, this is Candy. Can I ask, Jeremiah, are you asking about the data that Deb's just talking about, how we're defining what's being sent out to you, or are you asking about the self-report data?
The self-report data specifically for it, yes, ma'am.
Oh, okay.
So the definitions we have, although Deb certainly can do more work on this, I pulled up our screen. It is enter the total number of rehospitalizations within 30 days for any cause. Does that help?
It does. Maybe we might need to talk more offline for it because it seems so obvious, but again, the hospital, myself, and our vendors we report it never matches up. So I just want to make sure you get it right. So I think we'll talk offline.
These are the types that we definitely want to address right now in the beginning, too. So have anything that needs to be clarified, we want to get this really clear from the very beginning because we want to be collecting good data that means something. So we want to start collecting the exact same data from the working with the Maryland hospitals for the last year. They've kind of answered some of these questions, so we'll all get together and talk about this. But it is open for discussion for clarification. So thank you very much for the question, because I'm sure if you have that question, there's many out there that are having the same issue. So
Deb, this is Sheila, and we have a couple of questions in chat that I think would probably be better coming, answers would be better coming from you or maybe Candy. First is, what data definition are you, I would be specific when ICD-10 do you want, or more specific to severe sepsis and septic can address today, or if that's something we're going to address in more detail when we host the February 27th meeting.
I think we would. This is Candy. I think we'd have to get that specifically from Jennifer if they want the ICD-10 codes, because I don't know, Deb, if you have them. I don't have them right
I
here.
do not.
But Jennifer has them, and she uses very specific codes. So we could get that. We could probably do that on the 27th.
Okay. And then this is another good question. I think this would actually be applicable for both. And it's when will we get the Medicare VHHA data for sepsis? And like I said, I think that'd be a good probably thing to let the nursing facilities know too, just to review when they could expect their first initial baseline data based on the Medicare claim.
Go ahead, Candy.
Is the question I'm just trying to clarify, you're talking about the data that we're sending out to Medicare claims?
Yes, the Medicare claims data that we'll be distributing to both hospitals and nursing homes. When can they expect to?
So we'll have baseline data that will be available in February, like the very beginning of February. And then moving forward, it would be, we're looking, is it 3 months? So I always have to count backwards. So by March, we would be getting our first data reports. That would be specific ones, correct?
Deb, this is Wanda from the hospital side or VHHA, and we had the cost-setting webinar scheduled for April is when we would be data. And the hospitals will likely receive it before that webinar, but that webinar is scheduled for the 4th Tuesday in April.
Thank you. That's when we'll get back on our quarterly data review.
Correct.
Yep.
Deb, I have another question.
Okay, go ahead.
Question from Abdul.
Hi, Abdul.
Hi, how are you?
I'm very good. How are you?
Doing well, thanks. So I missed the last call that we had, but I know that you were saying that we're supposed to send you some information and also the team contact link, surveillance, and the baseline infection prevention assessment, the infection control assessment tools. Where can I get all this information from?
Oh, good question. So Abdul and everyone else on the line, I am going to be following up this webinar today with the link that you need for your completing your contact list of your teams and the baseline assessment for infection prevention. And also, it'll be in a separate email. I also want you to look for that box. That'll be separate from these two homework assignments. And maybe what might be the easiest thing to do is to send out, like, soon in the next day or two, these two links for the contact list and for the baseline assessment for infection prevention, and then I will follow up towards the end of the week with the box invite. I don't want anybody to get overwhelmed with this, and like I said, we're here to help you. I am a phone call and email away. If there's something that is prohibiting you from getting any of this done, just please let me know. Did that answer your question, Abdul?
Yes, thank you so much.
Thank you.
Once more, if you have a question, press *1 on your phone.
So while we're waiting for that, Sheila, do we have anything else? Now, I do want to let everybody know that we get copies of this chat. Any questions that we haven't answered today, plus clarification on the questions that have been asked, we're going to be compiling this list and sending it out after the webinar. So please put all the questions and comments that you have in chat. If we address them, we will be getting to them. But is there anything, Sheila, that we can talk about today from one of the questions?
Sorry, Deb, I put myself on mute.
I'm just getting ready to ask you that.
Yes, I think it looks like there's just a lot of people asking for a little bit more clarity around the readmission. So I think probably we need to just go back and develop maybe a resource tool with a little bit more definition around this so that we all can be consistent. I think that's so. Because there is another question about for readmission is it the index admission with sepsis or the readmission visits those out there working with us will be good.
Okay, and I think that's a great thing that we'll go through and compile all this, get our definitions or what we're asking. But like I said, once we send it out, please continue to drill down on these questions because it looks like you all are totally doing this and the experts out there too. So we want to make sure that we're all doing it exactly the same when we start collecting this. So I'm excited just to know that you're thinking about collecting the data. So thank you so much. Anybody else, James, in the queue?
No, we have no questions.
So let's just go back one more time, Sheila and Candy. Is there anything else that we can address from the chat? And then while they're doing that, please, everybody, I did see that our evaluation came up. So before you do sign off today, make sure that you complete that evaluation for us. And there's a place for you to put in free text. So anything that you want to let us know, please put it in there. Candy or Sheila?
See any other questions? I don't know that Sheila does.
Okay.
No, I do not. Thank you.
Well, I'm pleased to say that we're going to give you 5 minutes back in your day. Thank you again. As I said in the beginning, I'm extremely happy to be done recruiting and starting this work. We've got a lot to do over the next 2 years, and it's pretty exciting. I'm happy to be there with you. I'm going to reiterate again that I am part of the team. Please contact me. Let me know what you need. I'm really glad that we've got this discussion going like this, and I'm hoping that this is how it continues. Make sure that you put that date on your calendar, the February 27th from 11 to noon, and come with all these questions. We are going to have our analyst on the call at that time to show us what we have for data reports, and she'll be able to answer a lot of these questions. And we'll be talking about patient-family engagement. So think about what you're doing in your facility so you can bring that discussion to that webinar. And have a wonderful rest of your day. Thank you, everyone.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating.